Thank you, Dr. Kabir. So before we proceed to the next lecture, so I will be giving you a brief introduction about what you will be doing on the mannequins. So the mannequins are arranged in the second floor, one step down in 2 rooms. So you can go there and practice each mannequin 5 minutes time for you. The time that is given to you during the time of registration is holds strictly 5 minutes this side, that side we can adjust, but if you delay or if you don't go in time, I think the next person may not be giving you chance and you will have to wait till the end. So please stick on to your time. The timings are already told to you, and again if you want the times, we have a list at the mannequin place. You can know the timing again. So I will tell you the So the objective, why we need a mannequin training in anything. So the very important thing is that, so one has to learn the anatomy and one has to learn the skill of handling the instruments, and then one has to learn the depth perception, what distance your forceps is there to the foreign body, and how you should use the tip of the bronchoscope, and all those things cannot be learned on the patient, because to learn everything on the patient it takes lot of time. It takes years together to learn the art of any scopy. For that matter, even endoscopic sinus surgery or any scopy, it takes lot of time to learn. So learning on mannequins or animal models will be easier, and then the actual surgical procedure can be learned on patient. So it is very difficult for us to get cadavers to practice bronchoscopy. All of us know that it is very difficult to get. So then how do we learn? So the only way to learn is to do some mannequin training. So we lack mannequins in our country for tracheobronchial tree, and many of our postgraduates, in fact myself I have learned not on mannequins but on the patients. I took lot of time to learn, and even today we are learning. Every day we are learning. I cannot say that I have learned bronchoscopy. Every day we are learning, and I never had an opportunity of learning psychomotor skills as well as overcoming mechanical problems by a mannequin. So I thought that we should impart this knowledge to our youngsters, and then I have gone through some books where Chevalier Jackson has described a rubber tube mannequin where you can practice how to study the presentation of foreign body, how to grasp the foreign body, and how to know all the mechanical problems can be practiced on rubber tube mannequin before you really go in for a case. And then next thing what we have is the, so now this lamb mannequin was described in 1992. You see this journal ACTA. So 1995 actually he has described the mannequin, this one. So I have studied this and then made. So the rubber tube mannequin what Jackson had described was different from what I made. So he said that you keep a rubber tube on the table or a board, and then keep a weight or something so that this will not move. So you practice the art of bronchoscopy on the rubber tube, and you see, you take a foreign body which is similar to that what you are going together. It is a duplicate of the foreign body, and then you practice various positions possible and then try to remove the foreign body. So this is the idea that I got from lot of my friends, and then I took a 40 number Melicot's rubber tube, and then I discussed this with a very intelligent carpenter who actually made this without my, I told him, I brought him to my chamber and told what I am going to do, how I operate, what I want to tell, and what students are going to do. And when I said, he took the tube and then went to top floor and he came with this. So he came with this. Then I asked him why you kept this angulation. He told, sir, when you are operating, I saw that you are sitting and the patient is like this and the scope is like this. So I thought if I do like this, then the students and they cannot bend like this. So that was the carpenter mind. So he's a very intelligent guy, and he made this mannequin, and I just told him my requirement. That is what he made. So and then, so I myself practiced for some time, and then I felt that this is fairly good mannequin, rubber tube mannequin, to practice the art, how to grasp the foreign body and all. So you can have a look at this video, then you will understand. This is a 40 number size Melicot's tube, so wherein a foreign body is already kept inside. And you see, this is the common problem that we come across in our practice, that the foreign body is snugly fitting into the tracheal wall, and as you see, there is no forceps space. Now you see there is no forceps or insertion space, and you see the foreign body goes down and down like this. You will drive the foreign body into either right or left side, which is commonly. So now once, that is why tracheal foreign body is very difficult to remove, and then because the position it cannot hold there. So now once it goes on either side, so then it will be easy for you to remove. Now I changed my forceps to, because there was no forceps or insertion space, and now you can see the foreign body again it's moving. See, you hold the foreign body and then remove. See, I think it looks just like a trachea because of its red color and because of the size. So I think you can do a very good practice on this. Once you go back also, you practice. The main thing in foreign body removal is you will have to understand the depth perception. What is the distance that you have between your tip and the foreign body? If you understand that, game is over. So that is what takes lot of time to understand, and that is where you push your foreign body down and down. Okay, you can see here you have lot of space here, so that you can have a forceps space and you can easily remove the foreign body like this. So this is called as telescopic forceps. All the advantages, disadvantages of telescopic forceps, conventional, and all those things will be discussed by various speakers ahead. You will have very good understanding of about the instruments and technique of bronchoscopy in the lectures to come. So this is about the rubber tube mannequin. So again, another mannequin is there. What I did, so to simulate the human trachea, I can't get the human trachea, and I thought we'll get sheep trachea. It will be very easy for us to get, especially on Sundays. You can get a very good this one. You can select the size of tracheobronchial tree. So today morning our people have gone and got the very good sizes of tracheobronchial tree for you. And then see, this is the larynx is sutured like this, because when they cut the head, they can't cut without cutting the larynx. So the larynx is sutured with 2 or 4 sutures like this, and then fix it to a board. And again he made another board where you can see the tracheobronchial tree of the lamb will sit exactly. That was the carpenter had made. So that you will see this one. So this you see how a bronchoscopy was done on this. See, the larynx is lifted with the hand, and now you can see the larynx, and you can see the trachea, and you see the carina there. This is the carina, and you see the angulation is almost it looks same. This is the right main bronchus, and this is the left main bronchus, right? Anatomy of the sheep is almost the same as the tracheobronchial tree. You can see again the foreign body with a telescopic forceps is removed. So for you, we are not giving telescopic forceps or camera, we are giving you a conventional Khalil curl made telescopes, and then we are giving you foreign body grasping forceps and some peanuts there. You can keep the foreign body and study the depth, try to understand the depth perception. So the depth perception is as you go to the tip of the bronchoscope, then your tip of the forceps will shine with the light. That means that you have to understand that point to know that you have reached the tip. Many of people, they will not understand this, and by the time they will just go inside, the foreign body will be displaced somewhere else without your knowledge. So what you have to understand when doing a removal of a foreign body is that you have to understand that your forceps has reached the tip first. That will be known by the shining light of the distal illumination. That's the advantage. So then once you go there, then you remove all the secretions. Then your forceps should go 50% on above and below the foreign body equator to grasp it comfortably. If you catch only 25%, the chances of coming out fully are very less. You see now here, you see this clipping, you see it goes and goes like that because I am using a telescope with the conventional forceps. It is not the method that we use in the clinical practice, but here for recording purpose I used to show the forceps space. Actually it should go like that, and then see it goes beyond the 50% of the equator of the foreign body. Then you get the full foreign body in one piece. If you catch 25%, then only you will get 50%. Then you will make the one single foreign body into multiple. So that's it. So you can practice on the Manikin this one. And so we have to learn the hand and eye coordination. We have to learn during bronchoscopy. We have to learn that art of hand. So we are all ENT surgeons. We are doing day in and day out endoscopic sinus surgery. We all know the depth perception better than anyone else. So I don't think it will be a different task for us, but the thing is we will not have much time to do, and then there will be movements of heart, and then there will be secretions. In these things you have to work. So that is and you should have a good anesthetist. That is the difference between other scopy and this scopy. So psychomotor skills you have to learn, and then so the time given to you, you can go